begin with, we'd want to ask, what is prostatic artery embolization and when is it needed?
Prostatic artery embolization is a recent advancement in the management of benign prostatic hyperplasia. So, in easier terms, there is every male person who is above the age of 50-60, they start developing enlargement of the prostate gland. And as it enlarges, it causes compression on the urinary tube. Because of this, various symptoms are faced by the patients, which includes difficulty in urination. They have to go to urine again and again. They might have to wake up at night for urinating more than once, twice. So it affects their quality of life.
We'd want to know, why is this technique better than the conventional modality of management?
Right. So as I said, it is an alternative. It doesn't require any invasive procedure there is no risk of bleeding. So in TURP, especially patients who are on, say, some kind of blood thinners, there is a risk of bleeding that can happen. There are issues with incontinence. So urinary incontinence can happen in sometimes because of the urethral injury. There are sexual side effects like retrograde ejaculation, lack of erection. So these are the side effects that can happen in TURP but are not seen in prostatic artery embolization.
In your clinical experience, on the results that you have witnessed on your patient, and also along with the present literature evidence for this procedure, what would be your guidance?
So we have multiple randomized controlled trials. So where we have kept. So in all those cases, we have found that prostate artery embolization is non-inferior to the conventional treatment. Non-inferiority means the benefit is that it has lesser complication rate. Long-term results, even up to 5 years, are quite matching with the conventional surgeries. Per se, in our experience, the results are better, more than 95%.
What would be the message you want to give to the general physicians about managing the patients in their OPD post this procedure has been done by an interventional radiologist?
When do we start expecting results, how to counsel the patient regarding the results. So when the patient comes back to you and says, it's been 5 days, maybe it's not, I'm not able to understand whether I'm having a benefit, or the patient was on catheter and he asks us, whether I can now take off the urinary catheter or the Foley's catheter. So there we need to understand what is the timeline of benefits. Good effects start around 14 days, and by 28 days, we have a lot of the benefits have already occurred. Same with the catheters. We try the first, approach of removal of Foley's catheter in a catheter-dependent patient at around 2 weeks. So we ask the patient to come to us. We take off the catheter. We ask them to collect urine. Once they start feeling the sensation, we get an ultrasound done, check the pre-void volume, ask them to go and urinate. And if the patient is able to urinate well and the post-void residue on ultrasound is very less, then we understand that he can go home without Foley's catheter. So these are the ways we can manage the patient post-procedure, so that the patient always have certain questions. They have some small symptoms. If their GPs can take care of these small queries, they feel a lot more reassured.